We've talked a lot so far about the need for better evidence to inform guidelines. And a key part, as I think we've acknowledged several times, of being able to do that relates to having standardized measures, valid measures available to us, as well as the right data infrastructure to make this type of research more easily feasible. And so this really has been the focus, I think, of the US Deprescribing Network's Data and Resources Core and their working groups on data harmonization, as well as the measures working groups. So we will have 2 presentations, about 10 minutes per presentation, and we're hoping to have about 10 minutes for question and answer after each presentation. So our first presentation is by Maciejewski, who is professor in population health sciences and medicine at Duke University, and a senior research career scientist at the Durham VA Medical Center. And he's going to be talking about some of the efforts that the Data Harmonization Working Group has been working on.
Thank you very much to USDeN for accommodating me. I am sorry that I cannot be there in person to join you all, but appreciate the opportunity to present on behalf of our Data Harmonization Work Group. What I'm going to present is a collaborative effort from our group, and disclosures are listed here. We're funded from an R24, very kindly from NIA, and disclosures from collaborators on this slide, including my own Amgen stock due to my sponsored employment, and have some funding from these sources. So what is our Data Harmonization Work Group? We are a core element of the larger USDeN network, working in years 2 and 3 with actual data across 5 diverse US healthcare systems. 2 of them are integrated healthcare systems, Kaiser Permanente systems in Washington and Colorado, led by Drs. Devlin and Bayless, respectively. There's 2 academic medical centers, Duke University, where I am with my colleague, Dr. Hastings, and at Penn, where we're joined by Drs. Hennessy and Willis, and then 1 VA healthcare system that Dr. Hastings and I are also associated with in Durham, North Carolina. And so we are basically getting cohorts out of our data systems from these centers to try to bring to life some ideas. The general goal of our work group is to develop and then demonstrate with data approaches to measure important variables for deprescribing studies using data out of our EHRs. And we're hoping that some of these initial approaches will serve as proof of concept for key measures, both for covariates and, most importantly, deprescribing or discontinuation outcomes that can be operationalized across different health systems. As you'll see in a minute, we've run into some pros and cons of different approaches given different data structures, and are running into issues that clearly are going to require more investigation given how quickly our time is passing. And I'll just say, if anyone has questions, if it's okay to just hold them at the end, I'd be happy to address them. So why is harmonization needed exactly? Well, as you all may know, based on work by CoreNet and others, Sentinel Initiative and others, there's growing interest in using routinely collected data in medical records to be able to measure outcomes in trials, to be able to do pragmatic trials of deprescribing and of other interventions. As you may all well know, EHR data, since it already exists, even though it's collected for other purposes than maybe research purposes, it is more efficient and less costly than doing primary data collection and extensive patient recruitment prospectively. And because of some of these reasons, you can do pragmatic trials, which CoreNet has supported in a large extent, and also allows the study of very large populations depending on the inclusion and exclusion criteria for the studies. But a challenge in trying to do this work across multiple sites is that healthcare systems can be quite heterogeneous in many ways and have different types of data, which require some effort to harmonize. Different health systems are serving different populations and have different processes of care. For example, academic medical centers are maybe subject to different incentives, financial and non-financial, than say the VA is, or our Kaiser Permanente partners. Health systems may vary on whether they have only order data or whether they have order and dispensing data. That's proven to be a tricky piece of what we're doing, as I'll show. And then we need to try to provide a roadmap in some ways to help improve comparability across sites in a study, or a comparability across studies for future meta-analysis. And being able to do data harmonization can support rigor and validity of work that we derive out of retrospective studies or prospective cohort studies. And so the work that we've been doing, the approach that we've been taking, is we try to anchor our work around sort of a landmark trial, the Deprescribe trial, led by Martin and colleagues in Canada, that was published in JAMA in 2018, that was seeking to deliver an intervention that would help patients taking chronic benzodiazepines or other sedative hypnotics, get them to deprescribe over time as they were eligible for deprescribing, and it might help them in many ways. Since we do not have an intervention in the USDeN work, we're really mirroring essentially patients that are randomized to the usual care arm, because we are not introducing an intervention, and there was no sort of uniform intervention provided in this retrospective cohort study. So we're really trying to characterize what essentially patients might have been experiencing in the usual care arm, and trying to characterize in some sense what discontinuation might be going on in them. And so specifically, we have 3 activities. We've identified eligible retrospective cohort of people who are chronic users of BZD or Z drugs in our 5 sites. We're characterizing the baseline characteristics of these cohorts, mirroring what this Martin study included in their table 1, essentially. And then, most importantly, trying to construct alternative ways of characterizing deprescribing or discontinuation outcomes. And we're doing this across the 5 sites using data from 2017 to 2019. We identified chronic use of these drugs in 2018, and then are now looking in the 2019 data for outcomes. And as you might not be surprised, we have had some methods issues that we've had to work through and harmonize together as a group. And they're really in 2 big buckets. One is how to characterize chronic use of medications at baseline in this cohort, and then how to characterize the deprescribing or discontinuation outcome, because it's inherently different whether or not a site had fill data or only had orders. Because when orders are indicated in the data, we don't necessarily know if medications were dispensed and then actually consumed, so that's an inherent challenge in order data, as you may well know. And then there's also probably some degree of missing data across all our sites as patients are just at getting medications from other sources like Walmart, Sam's Clubs, and other places that we may have incomplete or entirely missing data on. And then health systems had varying ways of how the medications and drug classes were identified. So not all of us had Red Book data or GPIs, and so it proved to be a bit of a trick to come up with how we can be consistent in restricting, say, the number of medications that patients were chronically using at baseline, when we can't all just use GPI or can't all use NDC codes. And so harmonization for that proved to be a bit involved. And so we clearly had to identify who were chronic users of benzo or Z drugs at baseline. And so we took one of 2 approaches depending on whether people had dispensings or had ordered data. And I'm not going to read out the definitions, but they are shown here on the slide. And then that's maybe a fairly conventional baseline characterization of medications issue that everyone has to deal with in pharmacoepidemiology. But a definition of medication discontinuation and a retrospective cohort was relatively new to all of us. And so we've just started working through exploring two different approaches. The first one is what we call a fixed point or a time-based gap measure, which answers the question, did a patient have evidence of discontinuation at a fixed point in time? Say at 180 days after index or 1 year after index or cohort entry. The second measure was a moving window or gap-based definition, which is answering the question, did a patient have any evidence of discontinuation any time prior to a fixed point of 180 days or 1 year? And I'll be presenting results about this moving window definition shortly. So this slide presents information about our cohort of older adults across these 5 sites. And you can see the final cohort size at the bottom in the bolded black text. But one thing I do want to point out is that there was, despite the variation in sample sizes or sampling frames that went into the 5 sites, the proportion of patients that were chronic users of BZD or Z drugs was pretty uniform across our sites, ranging from 1.5% to 2.6% in the KPCL cohort. And the characteristics of the cohorts in the final samples from each site are here. So the average age was 71 to 73. A majority were female, except for in our Durham VA cohort, which is less than 3% female and is consistent with many studies in the current population of older adults in VA. There were a high proportion of patients with diagnosed anxiety, but there was a fair variability in the prevalence of diagnosed insomnia and fair consistency in the prevalence of diagnosed chronic opioid use, ranging from 14% in Kaiser, Colorado to a high 22% in Kaiser, Washington, and Durham, VA. And here's an illustration of a breakdown by age. You can see that about 2/3 or more were between 65 and 74. A vast majority of our cohorts were white. And when characterizing chronic medication counts of all kinds, you can see that polypharmacy was relatively common across all sites, with the most common categories being 1 to 5 or 6 to 10. And in terms of their use of benzodiazepines or Z drugs at baseline, the vast majority were only using benzos, but there was a non-trivial fraction that were using both at baseline. And now this may be of greatest interest to everyone in the room, which is this moving window definition of discontinuation. That is, among the patients across the, well, this is really focused on Kaiser Permanente, Washington, and these are really preliminary results. We're trying to understand what proportion of patients had evidence of any discontinuation of a fixed window any time in the year after index, after joining the cohort. And on the far left, you can see that if we characterize the requiring a minimum of a 30-day gap any time in the year prior from cohort entry to 1 year, we can see that 41% appeared to have at least one 30-day window of discontinuation. If we set a stricter criteria of a longer window of 60 days, that fraction that appeared to have a gap of discontinuation dropped to 26%. When we broaden that window to 90 days, it drops further to 17%. And when we have a very large window of 180-day gap or more, it was as small as 9%. And so that is, I think, a key finding about what we're characterizing in, if you will, the natural history of discontinuation in Kaiser Permanente, Washington. We're in the midst of generating similar statistics across the other 4 sites, and I'm sorry I don't have those for you today. So to this point, we've run into several challenges and, I guess, insights from trying to sort through those challenges, which is that healthcare systems, maybe no surprise, have different systems of classifying medications. And so because we don't all have the same way of classifying it, we had to come up with a different approach to trying to get a harmonized set of both baseline use of chronic medications and benzos. There was differences in whether sites had orders or fills, and orders have inherent challenges to them because if there's not dispensing, it's hard to know what the actual day supply was in a retrospective cohort. For that reason, the dispensing data is somewhat cleaner because you can see filling a medication and then refilling to be able to characterize how much day supply people had, and it's easier to identify gaps because you can characterize when refills weren't happening essentially, and thus more easily identify discontinuation. But we can't, in retrospective cohort data, distinguish between supported and clinically appropriate discontinuation from unsupervised non-persistence or abandonment by patients for cost or other reasons. So we can't really know why that gap exists if we see it. I think a more meta point that we've come away with is that it's really useful to work together across these varying systems to see how the sausage is made to try to do these discontinuation studies in retrospective cohorts. It helps us understand the different assumptions that we have to make and which assumptions aren't satisfied and so require workarounds that go into construction of variables that we would need to do before conducting any large-scale cohort studies. And then when defining the number of chronic medications at baseline, there's really big differences in clinical practice between sites because the VA in particular dispenses many more products, including many over-the-counter products like sunscreen and creams that one can buy over the counter that other systems do. And so there were a number of differences we had to factor in because of differences in clinical practices and formularies, essentially. So next steps are we're going to work on defining and operationalizing this discontinuation outcome, both the moving window one that I showed across the other 4 sites, and then the fixed point one that I mentioned at the beginning. And so we'll characterize rates of discontinuation and see how much what we showed in this earlier slide is mirrored in other sites. We're going to compare results using order versus fills in the same health systems that have them to understand if we get different results depending on the source of the data, which may be informative for sites that some of the trade-offs may be able to elucidate some of the limitations of orders more precisely when comparing results in sites that have both. And then we'll finish with drafting a white paper describing our activities and key learnings and recommendations that we can come up with based on what we've learned. And that's everything I had to present. Thank you very much.
Thank you very much. Really interesting stuff. As somebody who uses these types of data sources all the time, we have time for a couple of questions? And I can get us started if you all want to think about your questions. Oh, we have a couple takers, it looks like. Go ahead.
Hi, this is Scott Vory from the University of Florida. So one of the hats that I wear is I oversee all the outpatient clinics within the UF Health. So I kind of work well more on, not on a research, but more on an operational standpoint with the EHRs. And so I have a question and a comment. And so looking at the definitions of discontinuation, are you, at least from an ordering perspective, are you looking at the not reordering the medication as a form of discontinuation, or are you looking at like discontinuation within the EHR, the stopping of the medications? Because one thing that we have a lot of trouble with just in general is we don't really necessarily trust our medication list, because a lot of times a person is told to stop the medication but it's not stopped because it's someone else's drug and they don't want to do that, or they're not taking it because of non-adherence, or they're having a side effect but they should be on it and therefore they don't want to look like they stopped the medication because they should be on it. So I'm wondering if you can comment on kind of how you're thinking forward on looking at the order side of things.
Yeah, great question. We have to make an assumption that I think is imprecise, that if an order is not updated, then that is some evidence of a discontinuation. However, it could be the case, I think, as you're implying, that if somebody has, if in the absence of dispensings, an order may suggest if it was a 12-month, right, order for 12 months, either 12, 30 days supply or for 90-day supply, that in the absence of the dispensing data, a discontinuation might have occurred before that order was exhausted, but we simply don't see that. So there are real challenges with the order data, I would agree with you. And the assumptions we have to make are not ideal, but it's sort of the best we can do with what we have.
And then my quick comment on something that I learned over the last probably 6 months with Epic. I'm not sure what you're using at Penn or at Duke, but we get dispensing data through share scripts that's hidden somewhere in the EHR. So I don't know if you've been able to use that information as part of although it's not routinely collected, it's there and can be used. So that's one thing that we're exploring on our end, but I'm not sure if you're using that information as well. Thank you.
Yeah, great comment. We are using the SureScripts data at Duke because we do have Epic. And at Penn, they don't have that at this point, so have to rely only on orders. So if any systems are using Epic, I would definitely recommend getting the SureScripts data if you're able to, because I think it'll be more accurate since it gives you dispensing information. Thanks for the comment and question.
Hi, it's Dr. Paresh Paul here. I'm from Montefiore Medical Center in New York. I had one question and a comment. The question is this data freely available? Is it open source for other researchers to work on and use other multiple variables to come up with new research issues that can be worked upon?
Yeah, great question. I don't believe under the terms of what we're doing, we will be making this data available. I would need to check that with our lead, Dr. Dublin. So email me. If you email me, I can answer you specifically, but I don't believe we can make that available.
Okay. The reason I asked this question is having worked on previous similar trajectories, that's one of the issues that turns up, and it's one of the factors that retards research at a broader scale. Now, the second comment was, I'm going to start on a slightly different topic, but come to the same issue that we're talking about. When COVID began, the National Center for Advancing Translational Sciences started this stewardship where they were gathering data from more than 70 institutes all over US, including Epic and other healthcare records, harmonizing that data, and providing those data variables for anybody within the N3C enclave to use it, just to make sure that there's enough COVID research and people are there to work on it. Now, instead of reinventing the wheel, I believe there can be many things that can be learned from that initiative, which can be more helpful in the broader deprescribing thing that we are talking about here. Thank you.
Yeah, great research to make us aware of. Thank you.
Okay, if your question's quick, we can take it. Otherwise, we'll need to move on to the next presentation.
It's quick.
Go for it.
Sam Turman at Michigan. I'm doing a very similar study using electronic medical records. And the question is about your outcome is gaps and fills, and that involves assumptions about whether they stopped and why. Have you done validation studies against the actual charts in the electronic medical record? Because it's assumption about the gap representing the concept that you want, but just talk about the validation studies that have been done against kind of the charts in the actual medical decision making.
Yeah, great question. We have not done a chart review to validate this yet, but it makes a lot of sense, so appreciate the point.
Great, thank you. Okay, our second presentation will be by Noll Campbell, who is a scientist at the Indiana University Center for Aging Research and associate professor at the Purdue University College of Pharmacy. And he will be presenting on behalf of the Measures Working Group on their work on deprescribing intervention outcomes.
I am here not as a leader of this work. All this credit goes to Liz Bayless and her team at KP Colorado, but I am the stand-in candidate who was willing to accept the invitation to present in her stead. But I'll be presenting updates from the Measures Work Group within the Data and Resources Core. So this work group was convened with the charges that you can see here on the screen, first characterizing outcomes commonly used to evaluate deprescribing interventions, Secondly, prioritizing constructs most likely to be valuable for future deprescribing evidence generation. And then thirdly, inform operational definitions and applications for these measures. So we went about this with a few activities planned. First is to review existing literature of deprescribing studies that established a literature precedent for what had already been conducted, then guiding that, informing that through expert panel discussions. And the entire list of the panel I'll share with you in one of the final slides. But that panel discussion was intended to reflect on and categorize outcomes that had been previously reported and also influence what recommendations would be as far as prioritizing important outcomes as well as future work that we felt would benefit the field. And that was conducted through an expert opinion survey. So out of this work, a conceptual framework was derived, and I'll share it with you. I'll show you here in the first slide. And depending on particular populations, we all know that context is very unique with each drug and deprescribing relationship that we might study. So within a specific target population, we reviewed outcomes or following a deprescribing intervention, particularly medication outcomes or proximal outcomes become of importance. Those can be reported, as we've discussed already today, the number or quantity of medicines someone might be using and how that changes in response to an intervention, the appropriateness of those medications, the particular dose, the medication-free time. All of those are relevant outcomes that have been reported. Subsequently, the impact of those outcomes on clinical outcomes, or the impact of those medication measures on clinical outcomes, are those downstream effects that we've already discussed today that are the important clinical outcomes that may change in response to the deprescribing intervention, and ideally medication reduction. And those can include things like function, signs and symptoms, quality of life, adverse drug withdrawal events as well. And then the third category of outcomes that we considered were those that include utilization, quality of care, and cost of care. And those would be attributed or characterized into specific outcomes of interest. And then lastly, we didn't want to overlook implementation strategies of deprescribing interventions, as well as the impact on medication outcomes, and how those implementation strategies would affect clinical outcomes, system outcomes, from a perspective of scalability and persistence in the healthcare environment. So one of the tasks that the work group took on was to prioritize outcomes into high priority, low priority, and then within that, particular consideration to elements that you can see here. So first, within high priority outcomes, we quantified medication changes that could benefit from more standardized definitions. So we recognize standardization of definitions to compare between studies is particularly important, although we recognize one of the challenges is that each context is unique. And so we were challenged a bit with flexibility in setting about these recommendations. High priority outcomes also established measures which would benefit from guidance for applying to deprescribing studies, and were defined as outcomes that were essential for assessing deprescribing interventions, but for which measures were not yet well defined for that purpose. So lower priority criteria were those that were relatively well-established outcomes, and this would include things like utilization, mortality, adherence. There isn't much discussion needed on death, yes or no. So we felt like that was not raised to that was a low priority, deemed a low priority because there was not significant refinement that we felt was necessary. Outcomes, second low priority outcomes were those that could be incorporated into broader evaluation constructs, including patient satisfaction, attitudes about care that were potentially seen as indirect attributes out of deprescribing interventions. So below the next couple slides represent some examples of high priority outcomes, and this includes those that would benefit from better standardization. The first example is medication use. So example measures here would include number of medications, discontinuations, substitutions, and dose decrease. And so there's a fair amount of conversation here about what is appropriate for all studies versus each individual studies. And for a particular medication and disease state, one could make an argument that stopping a medicine is the most important measure for the intended clinical outcome or change in clinical outcome that was hypothesized to change. While a different study, it could be dose reduction or discontinuation, while a third study could be just dose decrease. So while standardizing those has value, we also, as I mentioned before, we're challenged with the allowance of flexibility that would be appropriate for clinical context. And so these were deemed, such measures or such medication use were deemed important to measure affecting downstream outcomes, but it also funneled some of our other recommendations about guidance for future research that will use these particular measures. Another example of high priority outcomes were among those established measures that would benefit from recommendations for applying to deprescribing studies. That could include quality of life, which the panel assessed as being a primary goal of deprescribing, and that there are many valid existing measures and that further work could benefit the use of either general measures or more specific measures that might be specific to a disease state. Functional status, and examples here would be cognitive function, physical function. These were deemed to be important outcomes in deprescribing trials, and that many validated existing measures exist. But further work could maybe further generate or specify between neurodegenerative diseases or types of physical function that were of particular interest. So again, areas of further measurement for applying to deprescribing studies: drug burden, treatment burden, that were deemed important for deprescribing and that measures are not yet well defined. Drug burden and treatment burden could be described as two different things: overall medication load or the burden of managing a disease state, such as not only taking a medicine, coordinating a medicine, picking up the medicine, administering a medicine for a loved one, communicating with providers can all be consumed within the term used as treatment burden, and further work could develop those specific measures. And then secondly, system implementation measures, acceptability, feasibility. Some of that has already been addressed in the prior session. And those were deemed, and so it's nice to have some repetition in what bears out in this product from the measures work group. So foundational measure development, we recognize that there is a paucity of measures that specifically define adverse drug withdrawal events, as well as recurrence of symptoms. And so this was deemed as important to generate evidence to inform deprescribing practice. This area is poorly defined and inconsistently measured. So I'll provide some example measurement recommendations. Again, this is not an exhaustive list, and I won't spend time with that, but I want to provide just some highlights. That specific recommendations for the field of deprescribing are to select clinically meaningful medication outcomes. We've talked about that a fair amount. Again, I've made the comment on repetition here is that for any given disease and treatment scenario, that medication outcome, that proximal outcome could vary, but the recommendation here is a bit more specific that we want there to be a justification for the medication outcome. So that we want to clearly define it so it can be reproducible by future studies, but we also recommend that these definitions provide rationale for why using that definition, and if not validation previously existing, to cite that or to develop that as you're writing future research. Considerations that we also suggested were to understand the feasibility, limitations, and reliability of data sources. That came up in Dr. Matt's prior segment. Understanding that there are limitations, understanding feasibility, and planning for that feasibility as you're planning future work, and accounting for that and addressing feasibility in that work is particularly important. And then lastly, measure medication changes temporally aligned with the intervention. And so recognize that we've talked about and highlighted the paucity of data on changes in clinical outcomes, but we have to recognize that if we change a medication within a 2-week period, that study period should accommodate the potential that the clinical symptom may not change beyond that 2-week period. So the common example here is cognition and measuring the change in medication exposure for a cognitive outcome. If you measure the proximal measure of medication changes, you may have to, in cognitive literature, you may have to wait 18 to 24 months before a measurable change in the clinical outcome can be achieved. As it relates to clinical outcomes, the recommendation is to select measures sensitive to change over time, if you can validate that. Again, a common example here that we use is cognition. There are measures that have been proven sensitive to medication effect, and those should be prioritized in such literature. Secondly is to design the study so it is powered to detect clinically meaningful effect size for downstream clinical outcomes. I heard that in the last session, and it's restated here that we recognize the paucity of change in clinical outcomes. So don't power your studies. The recommendation is, as much as you can, power your studies to not only measure the proximal medication outcomes, but also the clinical outcomes. And then lastly, choosing outcome measures relevant for target medications and medication classes as it relates to disease or symptom burden is the final recommendation. So here's the comprehensive list of measures work group. I think I got the top line here because I was willing to present. But I do want to recognize that the effort is distributed across this. And again, thanks to Liz for coordinating this. I'm going to end here, but just close with the comment that the recommendations from the measures work group that I've presented were just last week accepted by JAGS, and so we will have the benefit that, thank you, that when those are finally in print, or you could look very soon for the online ahead of print, that those will be available. So I'll stop there and invite any questions or comments.
Hi, I'm not sure if this is a question or a comment. It's probably halfway in between. So my name's Lydia. I'm from the San Francisco Bay Area. And I have a nonprofit. We are a group of former pharmaceutical advertising creatives. So I also currently work with medical school professors on shared decision making, but there are things that I saw my pharmaceutical clients do that I don't know if researchers could do or researchers aren't aware of. So for example, pharmaceutical companies do a lot of these types of studies where they're looking at interventions and how they influence prescribing, but they do have a lot of money. So they're buying access to commercial databases that bring together a lot of the type of information that we're talking about here today. It's very expensive to purchase the data, but could you comment on that?
Yeah, I'd love to. I think that's fascinating, and thank you for the comment. I think that falls a bit out of the scope of this context in the measures working group trying to influence the standards of future deprescribing studies so that they're done efficiently. What I understand you're talking about, though, is more consumer data to recognize behaviors of people that can influence willingness to deprescribe, that could be folded in almost as precursors of some of these proximal outcomes of medication use, willingness to deprescribe. That is also valuable, but not really, in my opinion, I don't think that's represented in this work, but it is an important point and something to think about as it relates to care outside of or impressions or willingness to deprescribe, perceptions among the community of deprescribing. And that, I think that falls outside of the scope of what we're talking about, but it's a relevant point, so I appreciate that comment. Any other questions? Okay.
Hi, Kaylee Hayes, Brown University. I just have a kind of question about the scope of these. Do you see these recommendations primarily applying to any, like, in terms of any study of deprescribing, whether it's observational or, a trial or a pragmatic trial, or, is this like specific to observational studies?
Yeah, they're written in a very general sense, and so the goal, I think, is to apply across the board, across the setting. Mm-hmm. And as I mentioned before, one of the challenges that there is variation in setting and disease that we tried to recognize and give people who are writing either studies that have been conducted or writing the next study, planning the next study, something to think about or reference to go through that makes that study efficient and it has a comprehensive set of items to consider from a design and a statistical perspective.
Thanks. And we're going to talk to you afterwards because some of us are working on for the International Society of Pharmacoepi guidelines specifically for like real world data observational studies and on deprescribing. And I think it'll be a great synergy in terms of this project, which is fabulous. So thank you.
Wonderful. Thank you. Next question.
Hi, this is Jinjia Wang from Rochester in New York. I have more like a question and a kind of comment combined in one. Is we know that one of the high risk, high reward area for or time period for deprescribing is transitions of care. We also know that from the world of observational research using existing data sets, the majority of them are focused on nursing home, long-term care nursing home. So how about the patients who are going through multiple transitions of care from the hospital to SNF, then to SNF to home, or from hospital to home with or without home health care? The data there are not that good, and the data are not always available to all the researchers. So one of the areas that I'm really interested in is home health care. And in home health care, even though we do home-based medication review as nurses for the patients, that data isn't always synced in the Epic system, because Epic is like a couple $100 million per year, and is beyond, is not affordable by most home health care agencies. So a lot of times the really important data are on the paper. They're not synced in the EHR. They don't get picked up by the administrative data sets like OASIS in home health care. So what do you suggest researchers to start doing in a space where there's not so much to grasp?
Yeah, great question. Great question. And if Dr. Matt's still on, then let's pitch that to the data group. It is a challenge, and I think recognizing that challenge, would suggest that you can respond to that challenge by creating your own system, right? That's an opportunity for innovation and validating, hey, all of this data source gives me this much information, this data source gives me this much information, but it's disconnected and siloed. So I'm going to create my own. And if you establish that and use it, that can be, if it's validated, that can recognize, I can work with that data, right? If it is designed to capture what you need consistently, and you can validate it, and it's credible and standardized, use that. That's my personal response, not a reflection of what how the committee might respond. But that's I recognize that challenge. But I think for me personally, I see challenges like that as opportunities for innovation, and you create your own system and work with them.
Exactly. So my comment is for the group that are working on the existing data measures and data sources, what might be helpful is if we can have like a guide for researchers who are interested in the field and don't know all the data sets too well, or the pros and cons of each data set. What do you need to be aware of when you're using OASIS? What do you need to be aware of when you're using PharmD? That will be a very interesting and I think very helpful low-hanging fruit to generate out of this. Thank you.
Great suggestion. Thank you.